Okay, so in this portion, we are going to go over a couple of things that come to airway interventions for some of these COVID-19 patients. Obviously, I would have donned and taken the necessary airborne precautions prior to entering this room. When we're talking about airborne, we're talking about procedures that generate aerosol. This time in intubation, chest compressions and things like that do generate aerosol. And so we want to have airborne precautions, which be the PEEP and everything else. So refer to the donning video for that section. We're going to cover a couple of things that we want to do with this patient to minimize aerosol generation. So typically in some of these rooms, we have bag valve masks or ambubags, and most of the times we're used to seeing them connected like this. In this case, we actually don't want to use an ambubag in these patients because of the aerosol generation. And so in some of the rooms, we will actually be having the viral microfilter as well as the PEEP valves. We'll also have the usual stylet in the bag, but we'll be using some sort of video laryngoscopy. I've not connected the machine just for the ease of demonstration at this time. And then the other device we're going to be having in the, you might have seen the Airway kits for these patients, is an LMA. And the reason we want to use an LMA is in the setting of a failed airway we cannot intubate, but want to try and get the patient's oxygen levels up without having to actually use the ambubag and generate aerosol. The way you want this series of devices to be connected, you want to open up the viral filter. That's going to be the very first filter. Most of the times the R2 respiratory therapist should be doing this. However, there are instances in which this is not being done correctly. So you want to just have familiarity with where this connects. So as opposed to your face mask being connected over here, you would actually be connecting the viral filter, and it goes only one way. So if I try and put it the wrong way, it's not going to go. So you connect that, and that's going to be your first outlet. And then the second thing you want to do is, you'll notice when you use these bags, there is passive exhalation that comes from the side port, and we actually want to block off that side port with our PEEP valve. And so the second device over here is going to be the PEEP valve. And put this on the side. The way you connect this, take the side port cap off. Shouldn't be much resistance there. And then attach the PEEP valve, and you'll notice numbers at the side of the PEEP valve here demonstrating that correlates to the level of PEEP. And if you want, you can just turn that down. That's got it about 10 of PEEP right now. So now there's no passive exhalation or any air coming out from the side of your port. Once you have that bag ready, you would go ahead and you would set your patient up and go ahead and intubate the patient under video laryngoscopy. Got your tube in. Once you have your tube in, it's obviously always a little bit harder in the mannequin, so I'm going to simulate my tube being in. Take out your stylet, and what would actually happen is that you would connect your viral filter to the actual stylet. Now, if you were going to be putting end-tidal CO2 to this, or inline end-tidal CO2, you would not disconnect this portion. This is what's being exhaled from the patient. You would be disconnecting that portion, attaching end-tidal CO2, and then attaching the ambubag there. If I cannot get my airway, like I mentioned earlier, we're going to be going to the failed airway device, and that would be the LMA. The nice thing about the LMA is you really just have to be getting the LMA down to the hypopharynx, and once you clear the hypopharynx, you can use that to bag the patient. In a mannequin, it is a little difficult, but in humans as well, you want to try and have some lubricant jelly, which is in all of the Airway kits. So what you would actually do in a human being as well as a mannequin, I'm doing the same thing here, putting my thumb in, grabbing the jaw up and out to create big space over here, and then actually taking the LMA, you can go backwards and twist it around, or just go straight in and shove it all the way down until in the hypopharynx. And once you're down in the hypopharynx, you would actually see on the side over here in the adult how much air you can insufflate. Here it says air 30.
So you'd actually take the syringe, pull up, and then go ahead and insufflate the airway. And at this point, you can actually, remember, do the same thing, keeping biofilter on, attach to the airway, and then go ahead and feed back the patient.
Tube through, and either you can just run the tube or a bougie and line it over, or you could just remove this after deflating the balloon and then try again using video laryngoscopy.